Kevin, you got an email in late November inviting you to HHS that was a little short on details, but seemed exciting. Do you want to kind of kick off the story there?
Yeah, I don't get too many emails from HHS, excuse me, but late November said, "Hey, we're announcing something on Thursday. Come out and listen in," which was followed up then on Monday by Dr. Oz and Abe Sutton, CMMI leader, announcing this new model coming out of CMMI called Access, and the conversation that entailed this week about Access, which was fun to learn about, listen in on as a good true Minnesotan. If I get an invite to a building that is the named after Hubert Humphrey, I'm always going to say yes to that. So
Yeah, you got it.
I get an invite there, and I'm like, yep, I have to do my duty as a Minnesotan to show up.
You
So
betcha.
I showed up there yesterday. It was fun learning more about the model. Certainly, there's a lot of energy in the room there from both startup leaders and the investor community, which, as we get into, I think is pretty natural to feel excited about it if you're in one of those two groups. But it was also interesting to me to see the announcements from both the FDA and their tempo model that's kind of tied to this access model around device approvals and whatnot, and also HHS's more like broadly announced AI strategy that also came yesterday, how they're using AI to empower their workforce, drive more innovation. Like it was a pretty cool cross, what's the right word? Cross organizational announcement from the administration that had a lot of energy around it. So it was fun to be out at it.
Yeah.
Yeah.
And you got to come to the nation's capital and you got to see some folks. It was really cool.
Yep,
Um,
for sure.
I thought where we could start was talking a little bit about kind of give the headlines on the program. So
Hmm.
Access stands for Advancing Chronic Care with Effective, Scalable Solutions. This is a CMMI model. Dr. Oz and Abe Sutton did the announcement, and I think like the high level takeaways for me was, and something you pointed out reflecting on it was this is a pretty key piece of their agenda in thinking about technology supported care. I think it's interesting um, because these things have been in the water for a while. We've been talking about how we can
Hmm.
better leverage technology, and it feels like a lot of those companies are stuck in the employer benefits space right now. And so I think the thing that was most exciting for me was um, like, can those companies make the jump to Medicare? And there's a lot of people on Medicare. It's a big market, and there's a lot of
For
need
sure.
there.
Yeah, I mean, this is kind of the theory of the case, as I always hear it, is CMS does something, sets a reimbursement agenda, and the rest of the country follows, right? The private payers follow that, et cetera, et cetera. And so, yeah, I think it's a pretty exciting move in that regard. It was interesting to hear Oz kicked it off on Thursday morning talking about, he's like, I'm getting the question, he said, I got it yesterday about what I'm doing about rising healthcare costs in this country. You quote whatever stat you want to on that. And it was clear that this is a pretty big part of that from their perspective in terms of how we're going to roll out technology to support more care in this country. And I think that is clearly a big part of the agenda going forward. And I think there's a lot to like conceptually. Like we'll get into some of the specifics of the model, but when you think about outcome-based payments, when you think about supporting more technology and driving the adoption of that, like there's a ton to like in terms of what they've shared so far. There's a lot more details, obviously, that'll come out over times, but I it's a clear indicator that Oz and the administration, CMMI, are supporting innovation in the space. Oz said as much, right? He's like, hey, we want more private innovation and we want to encourage that. And we'll happily pay for that innovation, which I think is like one of the interesting dynamics in all of this and part of why the community is so supportive of it. As we saw out there, I think it was the number they quoted was that 250 startups have already applied, or sorry, not applied, but indicated interest in applying, I suppose is the right way of saying that, because I don't think the application's out yet, but they've expressed their interest. They flashed a slide on the screen that has been all over LinkedIn about the names of the startups. So I thought that was interesting to see. And to me, the other high level takeaway is just that like we're still early in the process, right? Like there are a lot of specific details that still need to come out. How are we measuring these outcomes? How do things like risk adjustment play into it? So on and so forth. And so I think there's still going to be a lot to learn over the coming months. And if you're inclined to be skeptical of new efforts, like there are certainly questions that you can ask about how these things will be paid for, how much, so on and so forth. But in my head, at a high level, key takeaways: one, big broad part of the broader policy agenda moving forward. Two, clearly want to support innovation and view this as a key part of so doing in the space. And three, we're waiting on details as the program unfolds. I
Yeah.
don't know. Any other takeaways from you and all of that?
No, I mean, I think we'll get to kind of some of the other pieces of it as we talk through it. One of the things that I want to talk a little bit more about at the end is this is, I think, such a cool model coming from CMMI. And
Mm-hmm.
a criticism that you sometimes hear of CMMI is that, they take these kind of small incremental swings, and this feels like a big one. And I
Mm-hmm.
like to see that.
Yep,
Let's
for
kind
sure.
of talk through what the program, how the program is going to work. So in scope, examples that they mentioned of technologies, they talked about telehealth software, they talked about wearables, they talked about apps that coach people. As I was thinking about this, I was like, okay, immediately my head goes to Amada, it goes to Fitbit and Apple and Ura. It
Mm-hmm.
goes to, yeah, like those are, and then like a Teledoc or something like that, where they have a network of telehealth providers. But that's like
Yep.
what the kind of the proposed universe looks like.
Yeah, I think that's right. I mean, I think that again was that slide of all the startups, right? And there's the kind of to your point, there's the Whoops of the world, the Auras of the world, which as you think about like that broader agenda and conversation around like wearables for all in this country, like I think you can see how that's evolving over time if you look at the various announcements and things being said out of DC. So to your point on Apple Watches and things like that, like those, yes, seem very much in scope. And then that entire like venture backed chronic disease management category that's emerged over the last 5, 10 years, the Omadas, the Hinges, et cetera. Like I think if you're one of those companies and looking at this, you're going like, yeah. And not surprisingly, like that was the group of companies in the audience, right? It was most of those types of companies, their CEOs, their leadership teams who were sitting there learning about the model. So clearly, like that is it is certainly what it's going after.
Yeah. There's four tracks to the program, and they kind of picked the heavyweights of chronic diseases, right? So we've got hypertension,
Mm-hmm.
high cholesterol, overweight with obesity markers, prediabetes is that first track. Then diabetes, chronic kidney disease, heart disease as the second track. Third track is musculoskeletal conditions, and the fourth track is behavioral health conditions. And as I'm listing those, you can kind of start assigning startups that come to mind for each of those tracks. And you're
For
like, oh,
sure.
yep, that's going to be
Yep.
great for this. That's going to be great for these companies. Can you talk a little bit about and maybe kind of share about how mechanically the reimbursement is going to work?
So as I understand it, which again, like we've still got a lot of details coming out. There is going to be like the concept is payment for outcomes, right? So tying it to clinical outcomes. There is also going to be a co-management payment that gets made to the referring physician, I suppose, of up to $100 a year, which has prompted a lot of conversation in the primary care ACO community of like how the mechanics of that payment works out. But there's kind of those two vectors to the payment model. And I think my current understanding of it all is that we're still kind of waiting to see what that payment for outcomes looks like, how that's structured, how big of a payment that is, so on and so forth, right? I don't know. Do you have
Yeah.
any different read of it?
No, I thought that they had they were very thoughtful about thinking about the payment for outcomes, the relative to baseline. The example that they threw out was um, helping a patient with hypertension lower their blood pressure. Like that would be an example of, by 10 millimeter. I don't actually know what the unit is on that. And then Hg. But yeah, so it's like a tangible outcome, right? Like we know that
Hmm.
heart disease, hypertension, like these things are like a huge driver of all-cause mortality. And if you can bring that
Hmm.
down in a meaningful way, that's great. I
Yep.
think that the payment for outcomes, I always think in these conversations, it's important to sort of separate payment for outcomes and cost savings. Because if you're paying for outcomes, the lowering, like lowering blood pressure is great. It's not necessarily going to lower costs for the overall
Yep.
system.
Yep.
And so I think the outcomes piece and saying they're specifically focused on outcomes is a great way to escape the trap of saying like, well, it didn't affect overall costs for this specific patient. Like you can believe
Yeah,
in aggregate that like a healthier population is better and lower costs, but on any given patient, you're not going to get a perfect like that patient could trip and fall and break their hip the next day and it's not related to the hypertension and they'll be really expensive. So I thought that was an important piece of nuance. The
for
co-management
sure.
fee is also interesting. If you think about the way that, prescribing a therapeutic works, there's not any kind of co-management fee for that. Sometimes, if you're managing a chronic disease, you get you can bill for evaluation and management of that, but you're not like Pfizer or Eli is not sending you like a little thing every quarter saying like thanks for, making sure that our patient is taking this medication. And so it's you actually in a conversation earlier talked about this as, a sort of way to think about this is a doctor prescribing Omada or prescribing, a teledoc. And it's like that, but there is this sort of incentive recognizing that it's going to require a little bit more administrative work from the
Hmm.
physician.
Yeah, I mean, I actually like to me logically that part of the structure makes a ton of sense, right? Like you want to incentivize the primary care docs to be active participants in this process, supporting the referral pathway into these programs because that encourages the adoption of it and it helps coordinate care across the two, right? And like that'll inevitably be one of the conversations we have over time is like how the heck does all of that actually work in practice? Like, how do you get the voluntary consents from patients to enroll and get them aware of what's going on? And how do you get the data flowing back and forth with providers in a way that the providers actually use it? Like, there's going to be a ton to figure out in something like this. But conceptually, like we've talked in the past about how like your point on Eli Lilly, like the state of Texas has a lawsuit that I don't know if it's still active or not, but it was earlier this year where they were suing Eli Lilly for providing support for providers and prescribing certain drugs because the providers don't get paid for doing the assessments and so on and so forth. And so Eli Lilly was offering free resources to help get patients drugs. And the state of Texas said, hey, you're basically embezzling funds from our Medicaid program by doing this. And it's like, but like they're helping patients get drugs that these providers are saying they need access to, and otherwise they wouldn't get these support services. And it's like, I, I'm okay with incentivizing that, I think is my
Yeah,
general takeaway, right?
I don't have any heartburn on that. And I also this goes back to the point I was making earlier, which is it will probably not be the case that in the short term we're going to see cost savings because we're getting
Yeah.
people to utilize care resources that they weren't using before. And
Yep.
so obviously like on an outcome-based payment, like if you're able to move people's PHQ-9 score down, that's awesome.
Mm-hmm.
And you should get paid for that. But if they were just had untreated depression before then and they were just kind of like not using mental health, like it's going to be more expensive than the alternative case, at least in the short
Yeah.
run. And
Yeah, for
so,
sure.
yeah.
I think it'll be like you fast forward this, it's a 10-year program, right? You fast forward this over the 10 years. Like I think one of the more interesting questions to me will be so assume that it gets adopted, assume they figure out logistically how to do all of this stuff. To your point, I don't think this reduces costs of healthcare, which is part of the CMMI mandate, right, of rolling these programs out more broadly. And so I'm curious to see how they think about this over time and trying to demonstrate cost neutrality and or cost savings from this. Because just like looking at it first blush, it seems like you're essentially saying, hey, we're going to create a new profit pool for tech enabled services because we want to encourage and incentivize adoption of that, which I think is a reasonable thing to do, particularly if you believe they're going to drive these better outcomes. Now, like a lot of squirrely things can happen in that too. And so that'll be something to watch. But um, creating that new profit pool, if that is indeed what happens, if you're going to drive cost savings, that means you need to take somebody else's profit pool away in an industry where nobody wants their profit pool taken away. And so to me, that's going to be the natural tension that evolves over time in this type of a model when we're watching and seeing like, does this drive cost savings? The logical answer is probably not because you're creating a new profit pool. Can it
Yeah.
take money from an additional profit pool? I don't know.
Yeah, and I would argue again that that is okay because right now the status quo is that you have, we're resource constrained on
For
physicians,
sure. Yeah.
especially in a lot. So like we have to pay some people some amount of money to do the services,
Mm-hmm.
and tech has low marginal costs. So this is a sort of better than the alternative solution, which is train a bunch more doctors and force them to go to rural America and treat diabetes.
Totally. I mean, one of the really smart things I think they did in announcing this. So they had a panel on stage um, that included, I think it was the AMA, the ACC, and another association on the table. And they had them talk about why they were excited about the model and the role technology can play in transforming healthcare. And the point was made on stage of we've got a shortage of providers in this country. We need access to these sorts of tools to help roll that out. And I think getting those groups on, like, I'm sure that was intentional, getting them involved, getting them on stage, having them state those things. Because I could see one of the issues over time in a model like this is you get one group really excited about rolling it out, and you get all the other providers saying, well, wait, like, what about us? It reminds me a little bit back in the day a couple of years ago when the direct contracting model first rolled out, and you had companies like Oak Street and Clover shouting from the rooftops at how game changing it was going to be. That original Medicare now had a payment model that could bring over Medicare Advantage, innovative advanced primary care models to it. Um, there's a quote from one startup back at that time who was saying, "I feel like I'm like Charlie and Willy Wonka, and I got the golden ticket." And it like to me that like so perfectly sums up what the sentiment felt like back then. And like some of what I see on LinkedIn and other places about the sentiment related to this model today of the opportunity that it brings. The issue with that happened with direct contracting was the ACOs were like, well, what about us? Like, we've been a great partner to you, CMMI, CMS, in terms of adopting value based care and driving value based care. Now you're supporting these startups. Don't do that. You need to support us, your long term partner, in implementing these programs, right? And so to me, you can almost feel in the way they set up the day. Yes, we're really excited about these startups bringing innovation into the space. Here's the slide with all of the companies that are applying, not all of them, but the logos of the startups that are applying to the program. But also, here are the associations who are also aligned, signed up, supportive of the program, including the National Association of ACOs, to help drive forward the adoption of this. And to me, like it very much seems like they are trying to be thoughtful about how do we support providers, but also how do we support startups, help them work together by driving the technology infrastructure to encourage them to work, by having payments for both groups. To me, it makes a lot of sense.
Yeah. Let's talk a little bit about tempo. So
Yes.
one challenge if you have sort of like an innovative thing that you want to do on the, I guess, more diagnostic or monitoring front is
Mm-hmm.
that the state today, the state of the matter today is that you need FDA approval. and so,
Yeah.
and that's not famously not cheap or fast.
No, it's not. It is having worked in medical devices, the clearances, it's hard, takes a lot of money, so on and so forth. But this to me was an interesting move to try to align the two organizations across, hey, we're going to bring in these innovators, we want to support them. We're going to create this pathway where for access, you don't need the traditional FDA approval. We're going to use data. We're going to look at what's going on and keep an eye on it. But you're going to be able to use these devices for this program. I think the FDA in their announcement said they expect like 10 devices for each of those clinical conditions. And so, like, it's interesting to go back earlier in the year, right? Whoop had their little tiff with the FDA when the FDA sent them a warning letter for their blood pressure monitoring capability in the device, where they were marketing it as a medical device, and the FDA said you can't do that. You need the requisite approvals to be able to do that. And to me, it's almost like, again, they are seeing that issue. They are attempting to address that issue so that you can bring a Whoop into a program like this, have them participate. Ideally, get data to then, I would assume, help support the case for more, a broader approval, whatever that might look like. But like, it seems like a great idea. If anything, again, I'm like, what if I'm a provider not participating in this program? I'm like, well, why can I get access to this kind of stuff too? Which
Yeah.
maybe is also the intent of it because it's a cool little sandbox to play in. I don't know.
Yeah. I think it's cool.
Yeah,
Um,
agreed.
so one of the conversations you and I had offline about this is, as someone who used to work in the employer benefits healthcare space, I have a lot of empathy for businesses that are in that line of business, and trying to package themselves as part of an offering for
Mm-hmm.
self-insured employers. And if you like, the sort of conventional wisdom for a long time is like, if you can save people money on healthcare, the place to go do that is for a self-funded employer, which again, logically makes sense. But it's a
Mm-hmm.
tough business to be in. The outcomes take a really long time to show up. There's a lot of competition. It's just like it's like a tough business to be in. And so this
Yeah.
seems to me, for a company like Omada, which has since their beginning been like really dedicated to sharing clinical results and showing how they're able to move the needle, to be able to do this in a context that is not, for edge cases in the large group plan, and instead for populations that desperately need things like
Mm-hmm.
A1C management, is seems like a great opportunity.
Yeah, I agree. I mean, it's been interesting to see the stock market reaction to them this week, which you were looking at the numbers, right? Were any of them positive initially?
Hinge.
Hinges now, yeah. Um, it again, it reminds me of that direct contracting scenario when you had Oak Street and Clover. I mean, Oak Street at the time basically turned one of their earnings calls purely into a here is why this is transformational for our business and walking through all of the steps of how they were going to do that. I haven't heard that yet from the public companies. It doesn't seem like most of them are seeing a stock bump from it, which to me is indicative that analysts, whatnot, aren't seeing that either. I think it'll be interesting to keep an eye on that, right? Like, what's going on behind that they're looking at that they're not? Is it part of one of the things we heard in the community this week is about the complexity of becoming a provider under Medicare and how challenging that can be for businesses that have been focused on employers historically. And so I I don't know. It definitely seems like an opportunity and a tailwind for these businesses, but it also seems like there could be a lot of complexity and there's still some stuff to be worked out over time, right? To see how much of an opportunity that actually is for these organizations.
Yeah.
Conceptually, from a narrative perspective, if like I were the banker writing the IPO prospectus for, pick your next virtual care delivery company focused on employers to go public, I am all over this thing, right? I am like, hey, now we've got a pathway not only to be selling to employers, but get into that Medicare population. And then when this thing proves out in the Medicare population, that is going to flow down to everything else because that is how the world works in American healthcare.
Yeah.
So I I can see a narrative where it should play out, but it isn't yet, and so I think that'll be interesting to watch, right?
Yeah. I've seen, and I'm curious to get your reaction to this, two strains of skepticism
Mm-hmm.
in the community and on LinkedIn. And one of those is that the payments aren't enough for the doctors. And the other one is that the program is going to be a waste of money. I'm curious to
Mm-hmm.
kind of hear your takes on that.
I don't know, Mark. Like it's okay. So let's go on the first one once. The payments are enough for the docs. Like I don't know. We were trying to do the math on it, right? Like you're a primary care doc in this country. You have a 2,000 patient panel. You're serving. So original Medicare is what 35 million out of the 350 million in the population. So it's 10% of the population. So let's say a doc has 20% of their patients on traditional Medicare, and you're getting that $100 a year payment. Like you're talking tens of thousands of dollars a year in terms of additional payments to that doc. Like, I don't know. I get like it could be more, sure, but like that does seem pretty meaningful to me. So like that seems like the traditional PCP side of the world. I don't know that we know enough on the innovator side of the world yet to have an opinion on that. But like just conceptually speaking, if I'm CMMI leader, if I'm Oz, if I think back to like what I said Oz was saying at the beginning of Thursday, which is we want to pay to support innovation in the space and encourage that. It conceptually doesn't follow that they wouldn't make this an attractive payment option on both sides of the equation, right? So just like on the theory of the case, it doesn't hold much water to me that CMMI would not be paying well. Practically speaking, this always gets complicated and whatnot, and I'm sure somebody's going to have an issue with it. But I don't know. How about you? What do you think?
Yeah, I think, when we did the math, like if it's like 10% of your panel is on traditional Medicare, that's like 20 grand a year. Primary care docs make around 200K, NPs, PAs make a
Mhm.
little less than that. That's like 10+% swing if you all of that was going to the doctor. Not nothing. I think I agree like it could be a little bit higher, but I also think there's specialties like MSK where it's, 50, 60%. And if you're just like saying like we did the surgery, now go talk to Hinge, and you're getting a lot more. Uh,
Yeah.
that's also seems great. I think that uh, maybe this analogy is dumb, but I really think about it like we don't pay doctors to prescribe medication. Like if you think
Mhm.
Omada is what's best for your patient, and they made the case yesterday that the like ongoing management was not going to be a huge headache for the doctor. $100 seems great. I don't know. And I also
Yep.
think if you're a employed provider. This is like a corporate initiative that is in the universe of corporate initiatives that you get asked to do, maybe among the least annoying. Like,
Yeah. I mean, uh one of there were a ton of perspectives on LinkedIn and elsewhere posted this week, right? One of them that I enjoyed reading was from Harry Sag, who um, was talking about his takeaways from the model, and he focused a lot on the integration points and how challenging that will be, and how much thought needs to go into doing that well. And he made the point, he's like, at a health system that I worked at, getting the docs to like integrating anything and driving that behavior change is hard, even like inside the system where you're working at, let alone like bringing in outside vendors and partners and making all of that work together. Like that is going to be it's going to be a challenge in this for enterprise teams who are supporting docs to figure out like how do you make this seamless at the point of care so it actually happens, and like who's enrolling patients and how. There's going to be a whole dynamic to that. The other perspective I really appreciated this week was from Matt Kamen, who had a couple posts on LinkedIn. And one of the points he made was that like it's going to be ACOs who are the referral partners for these companies in this process. If he said, I think it's 54% of original Medicare patients are in an ACO today. So like that is going to be the bolus of where and how these patients come to these startups that are enrolled in the program. And I think it's going to be interesting to see like how does all of that work together, right? Like where are the partnerships forming? How does that data get shared? All that kind of stuff yet to be seen. And Matt made some really interesting points. I can put a link to it in the notes on this, but about there's some mechanics I think that are coming out in terms of like how this spend is accounted for in the baseline, where over the next couple of years there's like an arbitrage opportunity for 2028 it changes. And like to me, that is a good example of all of the details that like very policy oriented people are going to get into, and there's going to be tons of debates on this sort of stuff. And back to your point on like, is this program a waste of money? I find it hard to conceptually say that at this point in time. Like you can certainly make skeptical arguments for it if you want to. Startups coming in, are they going to be proven? Are they going to be wasting money and it's just a money grab from the venture backed industry? Like if you're inclined to believe that, I think you can probably make that argument. Or you can look at it and say, hey, we have a shortage of providers in this country. We've got a huge rural access problem. This needs to be a part of the solution, and it's worth figuring out right now. Like that also seems like a good answer to me. So,
Yeah. My feeling on this is like CMMI exists to waste some money. If they're not wasting money, they are not taking big swings on stuff that could be innovative or transformative. If CMMI is mostly generating, incremental positive returns, then they've really not done their mandate because incremental positive returns to Medicare is not path changing for the program.
yeah, I
There's
mean, I think it's a good point, right? Like it is energizing to see an institution like CMS via CMMI making big swings at trying to drive change. And like maybe it doesn't work out for one of a million reasons. And certainly we have seen the data from CMMI programs on not driving savings. I don't know that it means that like we shouldn't try these things, you know? And to me, if I'm in a role like this, I think it seems like a pretty reasonable thing to try. And again, policy wonks in DC can debate the specific merits, I'm sure, as like the payment model rolls out, and we see more on that as the outcomes measurement rolls out. How does risk adjustment get accounted for? How many people can be enrolled in these things? Like, there's going to be a million little questions to ask, but on the whole, it seems pretty cool to me.
there's as a kind of parting thought from me, and then I'll kick it over to you. When the UK was like after World War II was doing the national health system, they had this
Mm-hmm.
problem, which is that doctors didn't like it. They didn't want to be government employees. And the prime minister who finally got the NHS through, when asked how he did it, he says, "Well, we stuffed the he said it in a British accent, but he said we stuffed the doctors' mouths full of gold." And
Did he really?
yeah, and the mechanism for that was allowing them to continue to see private pay patients. Like they had to take NHS, but they could also do private pay.
Mm-hmm.
And I I think like something like this is like a tremendous opportunity to like stuff some people's mouths full of gold and get a good outcome out of that. Like if in 10 years there's a universe of people who are on Omada's like diabetes
Mm-hmm.
program who wouldn't otherwise, and their A1C is well managed. That was like I think a good outcome for that. And I think that like the way that you do this stuff, if we go back to high tech, the way you drive adoption in this country is what you make it really profitable for
Yeah.
companies to do it. And so I'm excited about this program. Like I feel really enthusiastic about it. I'm excited for the Omadas of the world. And I think that people saying like it's going to be a waste of money. It's like I hope we waste some money here because the opportunity is massive and we should try to
Mm-hmm.
pull it off.
Yeah, for sure. I I will add just 2 points to that I think follow along that same logic. That were sentiments that I heard saw in that room. One of which is that an investor mentioned to me they felt like the spigot was being turned open for this space, which to me is similar to what you're saying, similar to what Oz said at the beginning of we want to drive innovation and we want to support you via paying for that innovation and are happy to do that. And like to me, um, I I think that's a logical thing to be doing when you want to try to drive this change forward in the space. The second observation that I heard that I thought was interesting that I think you can see signs of here is that this administration has a big agenda that this is going to be one of the like key central pieces of rolling out over the next 18, 24 months. And we should expect to see more along these lines. But like you can start to see all of this connecting together in a really interesting way where if you assume this is not like the last thing that gets announced and there's more around this encouraging more interoperability, more technology supported care, um, maybe wearables for everybody in this country, who knows, like I don't know that I feel like we need to go that far necessarily, but I do think there's a lot of good that we can go along the way in terms of providing more access to quality options for folks in a world where we have a constrained labor supply of providers in this country and a lot of folks who can't access them. So let's open up the spigot for folks to get access to other types of, I think that's a good thing.